But anyway, yeah, I have the pleasure of talking about intrathecal targeted drug delivery, and I'm an IR, so I got here in kind of a convoluted path. I went to the military medical school. Subsequently, I trained in the military, did fellowship, everything. So I kind of progressed through my medical career. Can you hear me? Okay. I progressed through my medical career with people that I had gone to medical school with. And so based on the fact that there were limited hospitals, especially for certain subspecialties, I kind of tracked along with many of my classmates. And one of my classmates I was really close to was an oncologist. And I was at Travis Air Force Base. She calls up one day and she goes, what do you know about pain pumps? I was like, nothing. And she's like, well, could you learn about it? So sure enough, I literally just picked up the phone, cold call Medtronics, got connected. They sent me to a class, and in that class, I started doing intrathecal pumps and spinal cord stimulator. And one of my first patients was a gentleman who had been a forward air controller during Vietnam. And I don't know if you know what these guys do. They kind of sneak into places, and we laser now, but these guys would go in, provide reconnaissance, and then call in fire missions. So I go see this guy's got pancreatic cancer. You can't bump his bed. You can't talk loudly in the room. The lights are dark, and he's so just blasted out on opioids that he's calling out fire missions, just delusional. And basically, he was dying. So that was the first pump I placed on this guy. He cleared up with about 1 milligram of intrathecal morphine. He went back to woodworking, and about 6 months later, his son came in and said, Dad passed, but I really appreciate what you did for him. And as my mentor here says, you can take a lot of stuff from me, but you'll pry the intrathecal pump from my cold, dead fingers. What it does, the impact I've seen in patients' lives, it changes me. And you ask that question, why do you do what we do? You do it for those type of home runs in patients. And so let's dive in. So that's the SynchroMed 3 now. It's out. I'm still seeing a lot of SynchroMed 2 pumps. Not much different, some programming differences. So these are learning objectives. Some of these I don't think are appropriate at this level, like to discuss publication and stuff. I really want you to get your hands on and your minds around the idea of intrathecal pumps. So even before I go any farther, who has placed or who has had any experience with intrathecal drug delivery? Pump placement? Okay. Okay. Excellent. So hopefully we'll give you an introduction into this so it can become a little bit more clear. But we'll be talking about how to recognize the patient, review the indications, contraindications, and then we'll kind of tick through the procedure kind of step by step. And I think we have a station set up today also to talk about it a little bit more. So all of us here, this is what we deal with. We deal with some forms of chronic pain. One of the big things is the cost to society. Almost at $1 trillion. And if you read one of the asterisks below, you see that 560 to 635 is really based on really an undersampling of all the patients who are really impacting the cost of this procedure to our patients. By the time I'm getting to a lot of patients, specifically those with post-laminectomy syndrome or some other chronic pain issues or issues of spasticity, I've tried some of the more superficial things, and it's good now, as you guys see, we're fighting the LCD, the appropriate indication, getting clearance from a lot of our insurance companies to do the things that we know are right for our patients. But documenting that you had conservative attempts at pain control, documenting their opioid use. Once you start looking at all the different types of opioids people are using, you can go to something online called a morphine equivalency dosing, and you can look up and actually calculate how much, from an equivalent standpoint, they're taking in terms of opioids. But also just the look, like I said, decrease in quality of life, productivity, financial burden on individuals. One of the other things I'm doing in my practice now, I was talking to one of my colleagues here last night about the importance of just movement, importance of exercise. Before, where I was a little bit more kind of less watch and wait for my patients, my new standard is, can you walk 30 minutes a day? Can you exercise 30 minutes a day? Obviously, we know when you're moving those muscles, what it contributes to overall health is so significant that that's kind of one of my new standards. So if I find out what a person's interested in, some people want to garden. I'm out in Lodi, so a lot of great farmers. Some guys want to be back out in their tractor. But I set some kind of goal. A lot of times defining goals for your patients become, it makes it more realistic to you, because I'm sure you guys have seen people, you come in, had a guy who came in a wheelchair, did a couple of injections, worked with him, physical therapy. 4 months later, he walks into the office and I ask him, how you doing? He goes, no change. Well, obviously there's been significant change, because you remember when you came in with the wheelchair, or you do pain logs on a patient, you ask them, how did you do? Oh, it was terrible. I'm like, well, you wrote 0 for 3 days. Is this real, or is what you're telling me real? But frequently what people are saying to you is, this is how I feel now. They're not telling you about what your intervention might have done for them. So yeah, overall, big cost, a lot of quality of life loss, a lot of productivity loss. Then pain treatment, like I said, we're getting increased scrutiny. I went to Lisa Stearns, who at one time was like the biggest implanter of intrathecal pumps. She's passed, unfortunately. But one of the local attorney generals was at the meeting, and we asked him, so what happens if we do something and we just kind of screw up? And the guy's direct quote was, you're supposed to be smart. You're supposed to be, you should know better. We're going to call it RICO, and we're going to take everything you own. That was his response. So this idea that governmental scrutiny is definitely increasing. A lot of my patients, a lot of your patients are probably coming in saying, I can't get the same amount of drugs that I used to get. But as we look really a lot closer, we see that oral opioids were never meant to control chronic pain. And so benefits and risk of targeted drug delivery. One of the first things I find is that patients who come in on, they're on 100 microgram patches, 2 100 microgram patches that they're changing out every 2 days. A lot of those patients, I'll test them at 100 micrograms, and frequently out of the OR, I'll start them on 50 micrograms, and they have great pain control. But you see the different routes we can have. We can use oral, intravenous to transdermal, intramuscular. I just find when we get to that point in that appropriate patient population, intrathecal is just superior. Some of the risks are, though, this is more invasive. But again, I feel right ethically, because unless it's one of my patients, like it's one of my CP children, I see several patients who have severe spasticity secondary to stroke, or I have a patient with known malignancy. Bone mets are horrible. Renal cell with bone mets, horrible pain. Pancreatic, horrible pain. But a lot of times I'll do a celiac plexus block before to see if they get adequate pain control. If they get that pain control, but then they're right back in pain a couple of days or a week later, the intrathecal pump is the appropriate move. But obviously, we know with everything that we do, as we escalate and become more invasive, our complication rates increase. You see, this is kind of the standard discussion, whether we're using Infumorph or Prialt, ziconotide, which is some type of, I call it snail juice, but it's basically It's not an opioid, but it still has a similar effect on similar receptors. Patient selection criteria, like I said, if you have a patient that has pain related to malignancy, that's just a slam dunk. It's life-changing. But in those patients with spasticity or those patients with failed back syndrome, this is invaluable. But we have these steps that we have to go through, and just like with spinal cord stimulation, there is a psychological clearance that's necessary. Some patients can have a significant component of depression associated with their pain, and so just having a patient appropriately evaluated is just a must. It's one of those boxes we have to tick off. No untreated substance abuse, good luck in figuring that out. You can do blood tests, but if they've been on other opioids, you may pop something random, but and then a favorable response to a trial. Again, kind of one of the tenets of how I practice with almost everything is shaping expectation. So if I see a patient and after a while you see some of those backs that look like a grenade went off and it's just a little piece of bone here, I wonder sometimes how they're even walking. I start telling them then if they have focal mechanical low back pain, I really start selling them on, you're probably going to have a pump. A lot of times you'll find out with certain patients, a lot of the post-laminectomy patients will have some component of spasticity as well, spasms with that. So then I'll trial them. Typically, my typical trial dose, and I'm getting a little ahead of myself, my typical trial dose is 100 to 200 micrograms of fentanyl and 50 micrograms of baclofen. And then I'll track them with that for 1 to 2 days, and then based on their response and their duration of pain relief, kind of suggests to me now where I'll be starting with their basal dose. Again, contraindications. I like to hop in on body size because I trained initially in San Antonio, Texas, and they're just a little bit more huggable in San Antonio. And so one of the techniques I deliver, because they say you need to be 2.5 centimeters or less, but sometimes after you make your incision, I can literally I'm still not touching fascia. So what I do is I take 2,2-0 Vicryl and I'll sew them to the underlying superficial skin, hang them there, clip them. Then when I bring my pump in, I pass through there and I tie to those. And so now I'm suspended from the superficial, from the more durable superficial layers, and then I close. So that's not really an indication. And just knowing where we are going with our weight in America, you may be seeing more of that. And then spinal anomalies, most of the time, you definitely want to have some imaging because imaging frequently has saved me when I can't get in. Having that MR, a lot of times I'll pull that MR up and see. But sometimes conus is a lot lower than you anticipate. So just having that data available prior to going in. I'm Air Force, so before we drop bombs, we surveil. So surveillance, then you drop bombs. And so if you don't know your surveillance and you're going in, you're flying blind, and a SAM's going to get you. So advantages, provides physician-controlled dosing. That's really important to me because, again, a lot of times I'm shaping people's, even their interaction with their pain. Patients that have chronic pain, sometimes it becomes their family identity, and you see that their pain is sometimes even a manipulation of other family members. I love those patients because I will check you so quick right in the office. That may work at home. You need to cut that out. All the histrionics and blowing and huffing, I just look at them and then. So a lot of times my staff's like, I can't believe you talked to her like that. Somebody should have talked to her like that like 50 years ago. So again, a lot of times older patients coming in, one of the major complaints you see is on chronic opioid constipation and mental clouding. I have a lot of patients, again, in low to high for winemakers, they're farmers, and they like, I don't feel like myself. And then you mix that in with some gabapentin, which everybody's on at increasing doses, and grandma's like fighting space invaders in the middle of the road. And then, oh yeah, in California, make sure you throw in, probably here too, throw in the appropriate amount of edibles. Yeah, grandma went to one of the local dispensaries, ate an entire edible, and literally said she was fighting monsters in the road. Like, so you get the ability to control a lot of that. One of the other things that's not mentioned here, and I know there had been some early studies, when you control pain adequately, you decrease cortisol spikes, you decrease everything that cortisol does. What we begin to demonstrate is that specifically in the setting of pancreatic cancer, patients were living longer, and some of them, some anecdotal, like I have friends who follow 18 patients, 20 patients, 25 patients, and their survival was matching that of chemotherapy. So controlling pain, controlling breakthrough pain, and what it does to our overall systems, it's pretty damaging. So I think we have the ability to really impact people who are dealing with other, like I said, serious pain. Then the other thing that I've been seeing too, I read a paper, most of your patients who are dealing with chronic pain typically will have some type of adrenal suppression, hormone suppression. So I have a couple of patients, I call them the Eeyores, they kind of come in dragging. When you evaluate those patients, you'll see that they're typically hormonally suppressed. The men are really, really have depressed testosterone levels. And so turns out we're a system. As I said, these reference slides. Again, disadvantages, one of the big things is this is more invasive. It is a little bit more costly, but there's been some cost studies that showing if you can avoid 2 ER visits, you essentially paid for a pump in most locations in the country. So I'm gonna blow through some of these. It's just basically a bunch of things showing the effectiveness, activity, mood, environment, sleep, perception of quality of life, average pain, walking distances, normal work. All these things are improved in the setting of intrathecal targeted drug delivery. But what I wanted to get to was workflow, okay? So like I said, you've seen that patient. The spasticity patients, the patients with malignancy, no brainer. You're gonna be moving toward these. Outside of something like splanchnic pain, or organ-based pain, where you can try something like a celiac plexus block. And because some patients also, when you start to tell them, I'm gonna put this big brick in you, and they ask to see it and then they handle it, they don't want this. And so in trying to offer them some other blocks, I've had patients with some metastasis to the osseous pelvis, and I've gotten away with ganglion impar blocks and ganglion impar with alcohol ablation. I've had some good results there, anal rectal cancer, but overall, I'm prepping them for this. And then if it is that patient with post-laminectomy syndrome or something else like that, you are then working toward this pump. And when you find that patient who's like 5 years out from their laminectomy, I say 85 to 90% of my patients will transition to pump placement. So more patient selection you see here. That's the other thing too I see. I have some patients with multiple compression fractures, and me and Olivier, we talked a little bit this morning about, I was asking how many thoracic RFs do you do? And it's like not many, but a lot of times in those patients who've had multiple fractures in and around their fracture site, you'll see they'll have pinpoint facet tenderness and treating with RF in that setting. But when you now have that 7-8 level chronic pain, postural change, maybe some vertebral plana, so they have a little bit more kyphosis, that becomes a significant pain generator. And in that setting, again, I see a lot of patients who have a significant spasmodic component, so backlifting becomes really, really rich. And a lot of times, I went through a run where I had a couple of patients who had esophageal pull-through for esophageal cancer. And when they manipulated a lot of that smooth muscle, the real issue for those patients became spasm. So I did a trial with almost every known narcotic, and it wouldn't work. And patients just kept asking, and I ended up just trying baclofen. It turns out that a huge portion of the pain, or the majority of the pain, was really spasm related. And so transitioning that patient to a baclofen pump was really a home run. You talk a lot about weaning. And keep in mind, I think about the cancer patient and the chronic pain patient completely different, because if you have a patient who's basically dying, I'm trying to get them the greatest amount of pain as rapidly as possible, and weaning is not appropriate. But I can tell you, in almost every situation, there used to be another pump on the market called Flowonic. Flowonic is now gone, and they really kind of disappeared even in their support. So the reps that I had, they disappeared, everything. So when the Flowonic pumps start going down, what I normally see is we do a volume evaluation. They come in, and week after week after week, they're the same volume, and they're complaining about increasing pain. Get them scheduled, which is another 2-3 weeks. Get them in the OR. Get the pump changed out. I will always start them on 50% of their dose, because when you really look back at it, by this point, they've been without opioids for 6 to 8 weeks. So essentially, they're opioid naive again. And I start them at that lower dose. But I'll tell you, just based on experience, most of those patients I'm able to maintain at probably a 10 to 20% lower daily basal rate. And so obviously, making those nerves naive again, it works really well for those patients. And this points at how opioids are used. There is this line of thinking now that short-acting opioids in chronic pain is most likely treating issues of withdrawal and withdrawal-based pain more than it is their chronic pain or the pain they present it with. And for all the procedures that we do that has some type of a baseline evaluation before stepping full on into the procedure, I always will tell those patients, I really want you to think and even catalog what your daily pain is. Because a lot of times after I do a procedure, patients will come back complaining about access site pain and this muscle pull, and they won't clearly distinguish their presenting chronic pain issues with what you may have done in manipulating their soft tissue. So really getting patients to understand, so when they come back and they're now responding to the pain, you're asking them more accurately about their pain and not about any symptoms related to opioid withdrawal or any of your soft tissue manipulation. So again, there is a weaning protocol. I tell you about how I trial, and that seems to be our standard 50% pain relief. So that's what I'm looking for. And that pain relief could be 6 hours, that pain relief could be 2 days. I'm just looking to document how long they have had pain relief. And then, like I said, based on their response, that gives me an indication about how I will dose them. Sir, yes, sir.
It says a single bolus of 200 micrograms of morphine. Is that your standard trial dose?
No, I typically, I don't, unless people have some issues with, because people ask, what are you trialing with? I say fentanyl. Oh, that's that stuff on the street. I don't want any of that. I don't want any of that stuff. And so it's like, well, it's not a street drug because I make it here in the office. But no. So getting them through that, and then typically I will trial them with a milligram of Duramorph. Yeah. Yeah. Well, yeah, and keep in mind, and good question, these patients coming in are not opioid naive. They're not opioid naive. Some of these people, like I said, when you're on 100 micrograms of fentanyl per hour, and you got 2 patches on, you're changing them out every 2 days, you're flying high. So for you to trial with a milligram or 200 micrograms of fentanyl, it's nothing. The biggest thing that I see during my trials is a response where where you'll have some what am I looking for? They'll have like this dehiscence, and it leads to itching. So the itching and I'm blanking on the response, but yeah, that's what I'm looking for. You'll have that histamine response, and the itching is the worst thing I deal with during any of my trials. I'll hold them in the office an hour, 2 hours, but even within, and I give them Benadryl, so they may get a little sleepy from that. But within an hour, these people are up and walking around, and they've started their pain log. We finished their pain log training, and they're on their way out the door.
So really quick, just to clarify how much you're using 200 mics of fentanyl?
100 to 200 mics of fentanyl based upon what they're on.
Okay. How do you decide which you're going to use?
Eeny, meeny, miny, mo. I have this thing, and I know it's wrong, I call it my spidey senses, but looking objectively at what the patient has taken, the duration on that dose. A lot of these patients, like I said, are coming in with long-acting, short-acting, and some form of a patch even. Those people, they will tolerate 200 micrograms like nothing. But during a typical angiogram in an hour, hour and a half, I give 3 and 150.
So trial impact considerations would include morphine, and then I think Easy's protocol is fentanyl for shorter acting, which is a different scenario. You can make it shorter acting and discharge them or do it as a same day trial rather than, I keep people overnight typically. But the PAC guidelines start with morphine. If they're allergic to morphine, then hydromorphone, and then pre-alt and fentanyl. These are kind of the most common trials. Yeah. And the surprise at 1 milligram, I would give them 5 milligrams. 5. Because 2 duragesic patches, that's 100 micrograms, is equivalent to 480 milligram equivalents of morphine a day. And for opioid non-naive patients, I use the 1 to 100 ratio. For naive patients, I use the 1 to 300 ratio. So that's just good general.
Yeah, and any history of urinary retention, though, I definitely stick with fentanyl because you're going to see that is one of the things that I see starting off patients on Duromorph is that you'll see more urinary retention.
So one of the things that I was told is to put the patients on Flomax. If it's a male patient and you're doing a trial, put them on Flomax, just prophylactically so they don't get urinary retention.
We do that almost everybody.
With the intrathecal morphine, we know that there's biphasic respiratory depression, one occurring, around 60 minutes after a dose and another 12 hours even later. And when I think with lower doses in a trial injection, that may not be as big of a deal, but I wonder if you're having a patient with 200 mics or more, did you consider holding them longer?
Of Duromorph?
For late, yeah.
I very rarely trial with morphine. I just
morphine all the time, like almost every time. And in the last 1,000 trials, I've seen respiratory problems once, and it was probably related to the person's COPD rather than the morphine. I don't think I've ever seen, this is something that people always talk about, right? Jennifer, they always talk about it, but pragmatically, and I don't dose small typically. Did we ever see one when you were there? No. And you probably did 75 pumps. So.
It's just interesting, right? Because in anesthesia training, if you do intrathecal morphine for any anesthetic purpose, most of the hospital protocols include keeping that patient for observation. And in most instances, it's about 100 micrograms
Yeah,
for those
we-
procedural
So
doses.
I never underwent anesthesia training, but I believe that, and I keep everybody overnight. I still do, and I keep them for observation
Yeah.
because of this kind of dogma. But I think it's wrong. I just, or maybe over exaggerated. I just haven't seen that. And we dose 1:100 ratio. And so if somebody comes in and two Duragesic patches, I'm giving them 5 milligrams of intrathecal morphine, one pop. And they'll metabolize it.
Yeah.
They'll metabolize it fine.
Yeah, and like I said, most of these people coming in, they're on pretty significant doses of either fentanyl patches with breakthrough meds, and so.
So one other quick question. What do you do about the patients who have the itching with morphine? That seems to be, as you say, that's the biggest problem.
Again, with me, that's fentanyl, but all my patients get sub-Q diphenhydramine.
Yeah, and hydroxyzine is another
Yeah.
good choice.
Yeah. Yeah.
And it's okay, anesthesia will work as well, because if you do this and they itch, it's time limited. As soon as the
Yeah.
histamine kind of exits the body, it'll self-regulate. And I've never seen somebody itch for longer than 2 to 4 weeks. That's max, a month, and then it goes away.
Yeah. Yeah, most of those, especially grandma, I just found the diphenhydramine suppository it works great. That PR delivery, they do fine with it. But like you said, most of the patients, again, I kind of tell them what to expect. I give them the diphenhydramine, and I'll ask them afterwards to record the pain log. And you see most of the time, within a couple of hours, that has stopped.
And if you just use an H1 and H2 blocker, like Claritin and Zantac, over the counter.
Do you find that the need with urinary retention and the need to straight cath for this, is that dose dependent, or is it a patient specific kind of risk factor that you see in your practices?
It is a little dose dependent, but
Yeah.
Easy's right. And morphine, you see a lot more than the fentanyl.
Yeah.
But I use any male 65 or over gets Flomax, and you see it just that population is almost ubiquitous.
All right, it's a lot more of blah, 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 but any additional questions? Thank you, Con.
I do have a comment. One of the things I've never really understood is the kind of avoidance of pumps. And for people, I've also seen people that say, "Oh, you shouldn't do pumps. It's you're married to the patient." That comments like this. Have you ever heard that? So, what does that mean? I mean, I I follow my patients, and if they have a pump, I continue to follow them. But it's not like somebody came in with acute sciatica. I'm not married to you. You can't come back, or another fracture, something like this. I mean, for multi-site pain, for severe pain.
Can I turn here?
For people that are on chronic opioids and can't get off of them, for severe spasticity, for things like arachnoiditis, things like cancer pain. These are 6 things that only pumps take care of, only pumps. And these are not unusual things. Arachnoiditis is unusual. Multi-site pain in a female with degen scoli is not. Very common. So I think we, as a interventional pain specialist, you need to rethink pumps. If you ever talk to somebody that badmouths pumps, it's like talking to somebody that says something bad about vertebral augmentation. If somebody says something bad about vertebral augmentation, I know they don't do it. For sure, right? Oh, well, I do some of it. No, you don't. Yeah, I do some. What color, what do you use? What color's the drill that comes in that box? Well, okay, I don't do much. That's that kind of thing. And the people who badmouth pumps don't do pumps. It's the same thing. Everybody that does pumps to a certain degree, to any significant degree, loves them. And those 6 reasons are why. That's 6 good reasons why people who do pumps love them.
And then being independent.
Push the bottom
it
button,
just-
it puts a
it
dot
just
on the
makes
screen.
sense.
Okay.
Obviously,
That moves
you
around
know,
wherever
in
you want.
business, it's to
And the
return
top one goes,
customer.
gives the laser,
It's just a laser.
and then it moves right and
But
left.
this one actually gets recorded to
We're always
the
having these
presentation.
ethics discussions. I'm like,
So
when I look
we're
at a patient
pointing
who
out
has
to
a
people on the
pump,
internet.
and then that patient
That's what
has
I'm
had-
using.
Yeah.
has an IVC filter and they have a venous stent for compression, and then I've done the varicose veins, and I do ABIs and surveillance ultrasounds on them every 6 months. When you're in your practice, that just makes sense, and you're providing care. So now I know that I provide care for my community, because a lot of them, they don't know what PAD screening is, which should have started at 50. Then the other thing, if you undertake this one, the greatest things you can do is find a good nurse support quickly, because where you can run into some of the headaches is when you're trying to manage these on your own. So I have a nurse, and she's full-time working on pumps, refilling, reordering meds, and so it just makes your life easier, but you want to be married to your patient.
Amen.
Not correct.
I'll give you one more reason. So, and this is different than patient treatment. This is financial. So there's an equation for anybody here go to MBA school. So there's an equation. It's future value of current cash flow. And if you take a person with a pump, on the average, per year, they produce about $5,827. And for each 100 patients that you have, their present value of the future cash flow, for every 100 patients, it's worth $3 million to your practice. So you can do some quick math on that. And there's a lecture we give, and one of the components of it is, and we put this together because people have a misperception about, well, you don't make any money on pumps. We don't make a lot of money at one given time with anything except for the implantation, but the person comes back for refills, pump catheter and rotor studies, electronic analysis and reprogramming, and everything universally is paid for. And so the financials often are not covered, but there you go. And this is another pretty good reason to incorporate this into your practice to make it sustainable.